in order not to bore you, I have designed the slides for this presentation so that the background of each slide would represent thyroid in history and art. So, if you're bored or tired, just relax and enjoy art. I have nothing to disclose. Thyroid nodules are common in clinical practice, with non-pulpable nodules having a higher prevalence rate than pulpable ones. The prevalence rate of a pulpable thyroid nodule is around 5%. So, the most common pulpable thyroid nodule is the prominent or dominant nodule of multinodular goiter. A true solitary thyroid nodule is less common. The most important aspect of nodular thyroid disease is determining its nature, which allows, consequently, to provide timely and appropriate management. Fine needle aspiration cytology is the gold standard modality for achieving that. According to the Bethesda system for reporting thyroid cytopathology, 6 diagnostic categories are assigned. Bethesda II represents the benign category and has an implied risk of malignancy of 0 to 3%, and for which follow-up has been recommended. However, whether the diagnostic certainty of fine needle aspiration cytology could fit all thyroid nodule sizes remains contentious. So whenever a controversial topic in literature is approached, one should look for areas where potential refinements can be introduced. Most studies in literature assess the impact of nodule size on the risk of cancer in different Bethesda categories that have a variable implied risk of cancer. This influences the true predictive value of fine needle aspiration cytology because different Bethesda categories have different implied risks of malignancy. The higher the Bethesda category, the higher its implied risk of malignancy, and the less likely is that fine needle aspiration cytology would yield negative or falsely negative results. Furthermore, most studies assess nodules that are part of multinodular goiter rather than true solitary nodules. This again is a bias in favor of fine needle aspiration cytology. Although the risk of cancer per patient is similar when we compare patients with solitary thyroid nodules to those with multiple thyroid nodules, the risk of cancer per nodule in patients with multiple thyroid nodules decreases in a manner proportional to the number of thyroid nodules present. Our main objective was to assess the risk of cancer in solitary thyroid nodules 3 centimeters or more in maximal diameter reported as benign on fine needle aspiration cytology and its clinical implications. Secondary objectives included the impact of increasing nodule size and the impact of nodule consistency. From January 2015 to April 2016, 202 patients with solitary thyroid nodules 3 centimeters or greater in maximum diameter reported as benign following fine needle aspiration cytology underwent lobectomy. The indication for surgery was the relatively large nodule size, regardless of whether it produced compressive symptoms, underwent rapid growth, or represented a cosmetic concern for the patient. Importantly, all nodules lacked suspicious grayscale ultrasound features, and to us, these include irregular margins, the presence of microcalcifications, and a taller than wide orientation or shape. So, as far as the size is concerned, nodules were subcategorized into those measuring 3 to 4 centimeters in diameter and those greater than 4 centimeters in diameter. A receiver operating curve was computed for the risk of cancer, and nodule size is a continuous variable. As for consistency, we compared solid or predominantly solid nodules to those that were predominantly cystic. Among the 202 nodules, 46 were cancerous. Now, papillary microcarcinomas accounted for the majority of these cases. So 30 were papillary microcarcinomas, 7 were follicular variant of papillary thyroid cancer, 3 were tall cell papillary carcinoma, 3 were the non-invasive follicular thyroid neoplasm with papillary-like features, 1 for each minimally invasive follicular thyroid cancer, solid variant of papillary thyroid cancer, and classical papillary thyroid carcinoma. So the overall risk of malignancy was around 23%, and if we were to exclude non-invasive follicular thyroid neoplasm with papillary-like features, the risk would drop to around 21%. However, we did not note any size threshold at which the risk of malignancy increased significantly. Now, among the 46 cancerous lesions, only 50% were clinically significant, requiring surgery according to the most recent clinical practice guidelines. So, the overall risk of missing malignancy in this subset of nodules was around 11%. And the risk that you would require, that you would miss a cancer requiring total thyroidectomy was around 9%. Let's take a closer look at the results. As far as the size is concerned, when we compare both size categories, we can see that the overall risk of cancer and the overall risk of cancer that requires surgery or clinically significant cancer was comparable. Now, the only significant finding here was that if a cancer was found within the C2, or the category in which the size is greater than 4 centimeters, then it would more likely require a total thyroidectomy. So we can summarize this table by saying that the false negative rate of fine needle aspiration in this subset of nodules is around 11%, which is the risk of missing cancer that is clinically significant. When we compared nodules regarding their consistency, 10 nodules were predominantly cystic, and all 10 nodules were greater than 4 centimeters in size. When we compared these to all solid nodules, and then we compared them to solid nodules of the same size, we found that the overall risk of cancer, as well as the risk of cancer requiring surgery, was significantly greater in cystic nodules. So, in light of our results, and in concordance with the results of others, we feel that the implied risk of malignancy in this subset of nodules, according to the current edition of the Bethesda system for reporting thyroid cytopathology, is low, and it does not account for nodule size and or consistency. Therefore, we should change the way this subset of nodules is approached. Suggested viable options include short interval follow-up, applying scoring systems as assessment tools, repeat fine needle aspiration cytology, and diagnostic surgery. We support diagnostic surgery. However, we also recommend referring these patients to high-volume surgeons to balance against surgical morbidity, which is an augmented concern in low-volume centers. Limitations to our study include its retrospective design. The cytology slides of referred cases were not re-examined by our cytopathologists. However, there was no referral bias. Ultrasound and ultrasound-guided fine needle aspiration cytology are both operator-dependent, and 8 cases, 2 of which turned out to be malignant, occurred in the background of Hashimoto's thyroiditis, a condition whose status as a risk factor for cancer is yet to be verified. Strengths include no selection bias, no referral bias. The false negative rate here represents a true false negative rate, as all lesions that were aspirated eventually underwent surgery. We used a single Bethesda category, and we used solitary thyroid nodules rather than those that are part of multinodular goiter. We conclude that it is time to introduce refinements to the current edition of the Bethesda system for reporting thyroid cytopathology. For the time being, patients should be more actively involved in decision-making regarding their clinical condition and available management options. Thank you very much.